Thank you for joining us for the Hepatitis Foundation International's Lunch and Learn video series about various populations and their relation to viral hepatitis. My name is Jasmine Rich, and I am the program coordinator here at HFI. We are launching this video series to bring awareness to not only hepatitis, but also the new report by the National Academy of Sciences that says we will be able to eradicate viral hepatitis by the year 2030. HFI believes that a large part of the eradication process needs to be focused on hard-to-reach, hard-to-treat individuals, which include racial and ethnic groups, injection drug users, substance misuse, incarcerated inmates, Medicaid recipients, veterans, homeless individuals, and other groups not typically associated with viral hepatitis, such as renal patients and hemophiliacs. And what better time to talk about hepatitis eradication than May, which is Hepatitis Awareness Month. Today, I would like to welcome Mr. Marcus Hopkins from the Community Access National Network and Project Director of the HIV/HCV Coinfection Watch Program, who will be discussing viral hepatitis as it relates to the incarcerated population. Would you mind telling us a little bit about yourself, your area of expertise, and how you have become interested in the incarcerated population?
Absolutely. So as you said, I'm Marcus Hopkins, and I'm the project director of the HIV/Hepatitis C Co-Infection Watch, a project of the Community Access National Network based out of Washington, D.C. And I also serve as the organization's HEAL blogger, HEAL standing for Hepatitis Education, Advocacy, and Leadership. And there I write a weekly blog related to hepatitis C. I've been living with HIV/AIDS since 2005 and began my journey into HIV advocacy and education shortly after being diagnosed with AIDS in 2007. I entered into the health communication field in 2009 with an emphasis on HIV education and prevention in hard-to-reach, hard-to-treat populations, specifically in the Appalachian Mountain region, which is comprised of 420 counties in 13 states. Okay. So I kind of got involved with hepatitis in 2013 when Brandon McSada, who is currently the head of the AIDS Advocacy Association and a general consultant for Community Access National Network, which is CAN, contacted me to write a HEAL blog on a bi-weekly basis. This was in 2013 with the release of the first direct-acting agents to treat hepatitis C, Gilead Sovaldi and Janssen's Alisio. And those were the first treatments to truly offer a curative treatment that was easily tolerable. And so that kind of really helped launch my interest in hepatitis C. But because my primary area of study and research also focused on rural Appalachia where populations tend to be more homogenous, with minority populations tending to be located in more urban areas of the region, much of my HIV education and advocacy efforts had been geared toward people, getting people in remote, hard-to-reach regions in order to get them tested for HIV and to help break away from some of the stigma surrounding HIV that continues to linger in the region. Even in Appalachian states, particularly those in the southern part of the United States, a lot of the outreach included African-American population because they are disproportionately impacted by HIV infection in relation to their percentage of the overall population. So with that knowledge in hand, I kind of went into hepatitis C with the same assumption.
Okay. Well, thank you for sharing that. So next we're going to transition into the questions. The first question is, the National Academy of Sciences recommended in their most recent report on hepatitis elimination that screening, vaccination, and treatment of hepatitis B and C should routinely be implemented in correctional facilities. What is the best way to ensure implementation?
So it wasn't just the National Academy of Sciences that made that recommendation. It was actually the Federal Bureau of Prisons, and that's the body that has oversight of all federal prisons and whose recommendations are generally accepted and followed by state prisons and jails. They issued a similar guidance as of October 2016, and their guidance specifically addressed screening criteria for all sentenced inmates, all inmates with certain clinical criteria, and all inmates to request testing by adopting, and they did this by adopting an opt-out strategy of voluntary testing. So what that means is opt-out essentially means that the qualified medical professionals who are required to perform the screening inform the patient that the HCV screening is a routine procedure for every inmate and that they have the ability to opt out of the screening. So this differs from opt-in in that it requires informed denial of screening, which means that every prison and jail has to make it a part of their routine that must be offered to every inmate. And this is different than from informed consent, where hepatitis C screening is offered along with a list of other services. And the distinction is a little bit difficult to grasp when you explain it, but in practice, research shows that requiring informed denial of treatment increases the likelihood of inmates being screened in incarcerated settings.
The current rates for incarcerated individuals living with a chronic HCV infection are an estimated 12 to 35%. Will a better reporting system and more accurate rates help in the battle of hepatitis elimination within the incarcerated population?
Absolutely. So part of what makes gathering this information very difficult is the lack of definitive screening, reporting, and tracking requirements established by the government. So this actually applies to the overall population in general, but it is extremely important when it comes to incarcerated populations. With HIV, because of the initial severity and mortality rate seen during the initial outbreak in the 1980s, the Centers for Disease Control and Prevention, or the CDC, began adopting standards for screening, reporting, and tracking of HIV in 1993. Now, those guidelines have been updated with relative frequency, generally every year to every 3 years. And along with that, the treatment recommendations have been updated as well. But there have been in place very, very specific guidelines for how to test, what numbers to look for, and how to report those and track those numbers. With hepatitis C, the CDC has been far less definitive. The virus was only discovered in 1989, and only since 1992 have measures been put in place to screen all blood donated for transfusions, essentially eliminating hepatitis C from the blood bank supplies. And even then, the first treatment regimens for hepatitis C were approved in 1991, and those treatments remained both incredibly unpopular and hard to tolerate, with up to 80% of patients abandoning treatment prior to achieving a sustained virological response, or SVR, which is what medical professionals use as the baseline for curing hepatitis C. But beyond that, hepatitis C is more difficult to track in individuals because the disease itself has no definitive serologic markers that distinguish between acute hepatitis C and chronic hepatitis C. So the virus itself looks exactly the same. And around 20% of people who contract acute hepatitis C will not develop chronic hepatitis C because the body fights off the disease naturally without treatment. But the other 75 to 85% of patients will develop chronic HCV. In this way, it's difficult to determine without a concerted effort and collaboration between various departments and entities which patients have been tested more than once in more than one location and are therefore being counted twice, and which patients actually have developed chronic hepatitis C. The only way to really ensure that reporting is both accurate and reliable is to screen for it every single time. The biggest barriers to that happening right now are financial resources and a lack of a penalty for failing to do so. So right now, it's simply just too easy for inmates and the general population to slip through the cracks and not be screened. Incarcerated settings, there's really no excuse for failing to screen inmates. With rare exception, they're not really going anywhere. They are essentially a captive audience, and yes, the pun was intended, meaning that it is really the perfect population in which to require mandatory screening and reporting. And what makes this practice so difficult to implement is because, just like everything else related to hepatitis C right now, it's expensive. The side effects and symptoms for hepatitis C are far too severe for us to worry about front costs when the long-term expenditures from leaving it to become chronic hepatitis C will be exponentially higher.
It's a hard to reach how to treat population. Inmates are often overlooked during the fight against viral hepatitis. How can we make people more aware of the need presented by this population?
So the honest answer lies in standardization. In 2015, when the Coinfection Watch attempted to gather monthly hepatitis C reporting statistics, incidence, prevalence, morbidity, for example, only 1 or 2 states, I think Wisconsin was one, even bothered to mention their incarcerated populations in their weekly, monthly, semi-annual, or annual epidemiology reporting. And that's for all diseases. That's not just for hepatitis C. So basically, they were an entirely ignored population. Right now, we live in a nation with the highest incarcerated population in the world. as both a number and as a percentage of the population. And yet this population is consistently overlooked in terms of epidemiology reporting, in no small part because in the United States, we still have the mindset that, oh, they're just prisoners, their health issues don't impact the general population, or sometimes even worse, oh, they're just prisoners, they don't matter. Right now, research and evidence indicate exactly the opposite. Inmate health issues are vastly important because every single day, hundreds of inmates are being released back into the general population, along with whichever untreated communicable diseases they may carry. And at that point, inmate reporting really matters.
Mm-hmm. So what does the stigma attached to HCV look like among the prison population? Is it different than that of the general population?
So I think the primary stigma associated with hepatitis C is that of being an intravenous drug user. And that stigma holds true for both the general and incarcerated populations. But where that differs from everything that I've read is how that stigma is applied and who is applying it. In the general population, the stigma is largely a barrier to care on the part of the patient. For example, they don't want to be screened for hepatitis C out of fear that they might be perceived as an injection drug user. Whereas in incarcerated populations, the stigma is largely exacted upon the inmates by prison staff. So inmates actually are treated differently by staff. That stigma is no longer what if people will treat me differently, but becomes a matter of we will treat you differently. And another stigma with inmates who have hepatitis C isn't really a stigma so much as a reality. If an inmate is screened for hepatitis C, they become exponentially more expensive. Those inmates with hepatitis C are the most expensive inmates in the prison. So if they are screened with hepatitis C and the tests come back positive, the prison or jail is required by law under the 1976 Estelle versus Gamble ruling by the Supreme Court to treat those inmates. Financial pressures on the prison often lead to the staff treating hepatitis C infected inmates like pariahs because they're costing the prison money. Some staff and many legislatures act as if the inmates are asking for special treatment and treat them poorly in response. It's unfortunate, but without removing the financial constraints from the equation by increasing funding for pharmacy and healthcare budgets for prisons and jails, this type of behavior, as well as the very costly lawsuits the behavior inspires on the part of prisoners, will continue to be an issue for prison systems.
What interventions have been successful in reducing the incidence of viral hepatitis in the prison population, and how can they be improved?
So the most important intervention is honestly the first step. It has to be screening, and it has to be done every single time with every single inmate. There really can be no exceptions. And what this means is that federal prisons, state prisons, and municipal and county jails must screen for HCV in every inmate, and they must be held accountable for failing to do so. A positive test result, will, of course, require them by law to treat the inmates, whether they like it or can afford it or not. But without this intervention, there really is no chance of reducing the rate of hepatitis C infection in prison populations.
Are there programs that teach prisoners how to prevent and treat viral hepatitis? If so, how effective have they been?
So that's really a tricky question. So there have been really concerted efforts over the past 100 years to turn prisons away from being places of punishment to being places of rehabilitation. Now the results of those efforts can really vary wildly from state to state and even county to county, but that's really kind of an issue for another conversation. But inmate education about healthcare does exist within most prison systems. But the trick is it has to be implemented in order for that to really help. So unfortunately, most of this education occurs after a patient has requested screening for a disease, or worse still, after a positive test result has been received. A lot of prisons and most county and municipal jails don't have 24/7 medical support staff on hand, and those are the people who are best suited to educate prisoners about treatment and prevention. And this is one of those facets of rehabilitation that really slips through the cracks because, obviously the patients don't receive if the patients don't receive the education or the right information for that matter, the programs aren't really effective on a broader scale. I mean, there are some prison systems that offer workshops for inmates, and those interventions have shown moderate success. But, it should also be noted that in the 2016 Federal Bureau of Prisons guidelines that I mentioned earlier, 5 organizations are mentioned for patient education, one of which includes the Hepatitis Foundation International. So I think I know a couple of people who work for them.
I just want to thank you, Mr. Hopkins, for taking time to speak with me today and helping educate our viewers on a topic that previously may have not been on the radar. So thank you again for participating with me today.
You're very welcome. Thank you so much, Jasmine.
Bye-bye.